Thank you. All right. We're back. This is Senate Health and Welfare, and it is still January 31st. Hard to believe. So we're moving on to S-151, and here's our goal today. I know we've looked at this bill, and we understand that there are sections of the bill that have already been addressed previously or are currently statutory, and so we want to look at the sections of the bill that we can take out and then consider those sections that are left. So that's the job for us today. And so there may be some sections that become ambiguous to us because we think they should be stronger or weaker, and the committee wants to keep those in. I'm thinking in particular of the primary care piece, the 12% or whatever percentage that is in there. So, so Jen, why don't we put the bill up and we'll go through it one more time and with a consideration of, and you'll have to help us with this because I know things have happened, other committees, and I know our committee has done some work on sections of the bill already.
All right. Good morning, Jennifer Carby, Office of Legislative Counsel. So this is S-151, and we have gone through it. This is an act relating to pay parity and transparency in healthcare. It was introduced last year, so some of the dates in it are already out of date, would need to be updated at a minimum. The first section deals with the Green Mountain Care Board and healthcare contracts. It would direct the Green Mountain Care Board to collect and review a representative sample of healthcare contracts and fee schedules from insurers and come up with a methodology or propose a methodology for how to increase the transparency around healthcare contracts, including standards and criteria that the board would use to review healthcare contracts and fee schedules, and any recommendations for legislative action. And then it has a provision addressing the confidentiality of confidential information. So this section has not been enacted in any other legislation and is not, to my knowledge, in any other bill that is moving.
So if we leave it in, we can take testimony and then determine what to do with it going forward.
Right.
Okay.
Section 2 is on the blueprint and directing the Director of Healthcare Reform to recommend amounts to increase the per person per month payments in the blueprint. This was enacted last year, and I believe that report has likely come into you already.
So we can take section 2 out.
Okay. Section 3. Sorry.
Okay. No. Thank you.
Section 3 would enact some legislative intent language around Medicaid, the Medicaid program reimbursing all Medicaid participating providers at rates equal to 100% of the Medicare rates for the services provided, with first priority for primary care, and directing the Department of Vermont Health Access in its annual budget proposal either to provide reimbursement rates for Medicaid participating providers for primary care services at rates that are the equivalent to Medicare, with annual indexing involved, or provide information about the additional amounts that would be needed to achieve full reimbursement parity for primary care services with Medicare rates. So there was a one-year version of this language enacted in Act 167 a couple of years ago. This would make it an ongoing provision.
Okay, why don't we take testimony on this one as well?
Section 4 directs certain regulated insurers, basically any insurer with 500 or more covered lives, the state employees health plan, and the VHI plans, to increase the percentage of their total healthcare spending allocated to primary care by at least 1%, 1 percentage point per year until primary care comprises at least 12% of their overall healthcare spending. And then once they achieve that 12% primary care spending allocation, they would need to maintain or increase that amount annually. And there's certain things that are specified that their increased proportional spending on primary care cannot do, cannot increase health insurance premiums, be achieved through increased fee for service payments to providers or increase the plan's overall healthcare expenditures. And then it would have them reporting annually to the Green Mountain Care Board on the percentage of their total healthcare spending allocated to primary care during the previous planned year, and would have the Green Mountain Care Board reporting to this committee and others on the progress that the payers are making.
Well, I mean, we certainly can look at this. I think there's been a lot of discussion around this, but it makes sense to maybe look at that percentage again, and some of the issues around it. So we'll leave that one.
Okay, section 5. This is the language that would require the Commissioner of Labor to annually update the schedule of fees and rates. Update at least biennially and on a consistent basis the rates paid to providers for services delivered through workers' compensation plans. So that is section 5.
Any comments there? Something we can look at.
Section 6 is a long section dealing with exemptions from prior authorization requirements. We can look at it if you want, but this is the same topic as being dealt with in H766 in the in-house healthcare, which is actively pursuing exemptions from prior authorization requirements and other administrative burden issues on providers.
You are, and I understand that they're updating the language, so it makes, I think, we'll let them deal with that one over there.
All right.
We can take that one out.
Yep. And then we have several pages. It's going to take me several pages to find our next section here. Try not to make you all too busy. Oh, here we go. All right. Section 7, actually 7 and 8 deal with sexually transmitted infections. So a few things to say on this. The first is a section that would authorize a minor to consent to.
Can you hold on a second, Jen?
Yep.
What page is, page
16.
Yeah, 16. 16 on my, okay.
So this
17, 15.
We found it.
Section 7. Yeah.
Section 7. I have it on page 16.
Yep.
So this section would add a couple of sections in Title 18. One is on consent to preventative services for prevention of a sexually transmitted infection by minors. And the other section would allow minors to consent to treatment for sexually transmitted infection. A couple things to note here. One, what is proposed as Section 1108 is actually already authorized under existing law. It's just a little harder to find because it's in the section on consent to treatment for minors dealing with dependence on regulated drugs or alcohol. That same section is being amended or proposed to be amended actually in S18, the flavored tobacco ban bill that as it came out of House Human Services. But there is not an existing provision on consent to preventative services for prevention of sexually transmitted infection. So if you wanted to approach this topic, we could do it in a couple of different ways. One would be just to enact the consent to preventative services by minors. The other would be to pull out the sexually transmitted infection language from the existing statute and move it here to be with the preventive services. Or you could add preventive services to the existing statute. So several ways to deal with this if you want to approach it. But some of it is already covered.
Okay, let's go. That was a quick.
Can I just ask a clarifying?
Sure.
It's,
Yeah, go ahead.
Section 1108 is the one that's already in current law. It's just in a different place. Is that correct, Jen?
That's correct.
Okay, thanks.
So, and this, and is it, you indicated that S18 would have something included with 1108?
Yes, so where the existing statute is in, I believe it's 18 VSA 4226 or thereabouts. It's in the regulated drugs statute.
And it was passed in 1975 is my understanding.
I believe it was actually passed in 1971 and amended in 1976 and then not touched for a long time, which is why it uses the language venereal disease. So the S18 version is making a number of updates, including updating the language from venereal disease to sexually transmitted infection.
So if we took that section out, 1108 out, it's already being covered.
It is already
House.
being, right, it is already being covered. You
Okay.
could decide if you wanted to keep these provisions together. You could add consent to preventative services to that existing statute in the regulated drug chapter. There's many ways of approaching it depending on what the committee's goal is.
Okay, so I'll leave it to, in terms of 1108, I think it makes sense to remove it since it's already being discussed by the House. 1107, we could leave it in for purposes of discussion and testimony, or not.
What would be the advantage of taking it out and just to move the bill along, or
Which one?
the 1108?
Because it's already being dealt, it's already statute. The only change there is, said, Jen, you want to explain again?
Yeah.
Where 1108 currently exists?
Yeah, so, and I don't know, here, I'm going to take this down for a second. I don't know if it's helpful for me to put up the existing statute. Would that be
Sure. That'd be
helpful?
good.
Okay, let me do that.
Yeah. You know, this is these two sections are sections that have been kind of a lightning rod for people. So I think it's really important that folks understand what is currently in statute and what change is being suggested in the legislation.
Yes, and it may also then be helpful to look at well, yes, there are a number of updates being suggested, so the language is quite outdated. As you will see, there are a number of updates included in what House Human Services is recommending in S18 because their amendment includes allowing minors to consent to cessation treatment for dependence on nicotine and tobacco products. And so they've updated the statute. But what it currently says is if a minor 12 years of age or older is suspected to be dependent upon regulated drugs, which is what Vermont law refers to.
Jen, we're not seeing it. We're seeing what your screen is showing us is S151 and then the web page.
Well, yes, because it put up the wrong one. Sorry about that.
Phew.
It was showing it to me. Now can you see
There
it?
it is. There
Okay.
it is.
Well, I'm glad it didn't show you something worse. My email. All right. So in the existing statute, it says if a minor 12 years of age or older is suspected to be dependent upon regulated drugs, which is what our statutes call controlled substances, to have venereal disease or to be an alcoholic, and the finding of such dependency, disease, or alcoholism is verified by a licensed physician, the minor may give consent to medical treatment and hospitalization, and then there's separate language for a drug dependent or alcoholic person. And it specifies that consent under this section shall not be subject to disaffirmance due to minority of the person consenting, which basically means even though minors typically are not considered to have the capacity to consent based on their age, in this case, they do because the law is specifying it. And the consent of the parent or legal guardian of a minor consenting under this section shall not be necessary to authorize care as described in the subsection. And then finally, the parents, or legal guardian shall be notified by the physician if the condition of a minor child requires immediate hospitalization as a result of drug usage, alcoholism, or for the treatment of a venereal disease. You can see the section was added in 1971, amended in 1976, and then a technical amendment in 2018. So that is the existing law that allows minors to consent to treatment for a sexually transmitted infection, or as it refers to still, a venereal disease, but does not allow them to consent to preventative treatment or preventative care.
So 1108 is already in statute essentially. So
Right.
I'm thinking that we don't need to we're not making changes to that. That wasn't the intent. And then the other one is 1107, the prevention piece. Has that been discussed or dealt with at all in the House?
No, because the context of the House bill was
Right.
really the tobacco and nicotine usage.
Well, I leave it to the committee if we want to leave that one in as prevention, allowing for minors to receive prevention information around sexually transmitted infections.
So if you're asking,
I'm asking.
my recommendation is no. It's serving as a lightning rod.
Right.
I'm getting more communication about this particular topic. They're completely ignoring the 7 other topics that you've got in the bill, and won't be able to support it in its current status.
Okay.
Well, I guess I want to give it some more thought, but I'm leaning toward yes, leave it in. It's important. Prevention is really important, as we've discussed previously.
Okay, so this one is a qualified leave in, and we'll hear from Senator Hardy, but let's leave it in for now. And it is a lightning rod. I agree with everyone. It's not comfortable when someone reacts to one specific section of a bill, and it's really changing, providing information. And one thing I will say is that when kids of a minor age go in to see their physicians, it's my understanding that primary care and pediatric primary care includes families, includes parents in those visits. So there may be cases where they're not because of abuse or other situations, but you want to ensure that kids have the information they need to prevent serious disease. I'm fine with leaving it in, but I don't like the idea that it will be used for other purposes. So we'll leave it in for now, and then we'll see how it goes.
Can I make a quick comment? Just in terms of it being a lightning rod, the emails that I'm receiving, I think.
1108.
Yeah, I think folks are conflating the treatment and the prevention, and they don't understand that the treatment piece is already in statute. So I've had to clarify that with folks, and then they usually come back to me and say, oh, I didn't understand, I didn't know. So I do think there's some confusion happening.
Okay. Well, let's see what happens then. We'll take testimony.
So then, sounds like we're gonna have to do a bill to repeal that section, because I don't think a 12-year-old child has no capability.
That is a totally separate issue, and if you have a bill that you want to introduce on that, that's legitimate.
Yeah, I'd just like to say, I think the conversation that has become the lightning rod is what is the age of consent? What is the age of maturity? Whatever you want to call it. Because we're spanning from 12 years old up now to 26 years old, and somewhere in between is the right spot, and we're cherry picking all over the place. So
Okay.
my point is, that kind of conversation embedded in a large bill with multiple relevant topics is very distracting for everybody.
And the intent of that was just to change the language from venereal disease to sexually transmitted. No.
But it's raising awareness.
No, you're right. You're right. It is distracting from the other components. So, but we'll leave 1107 in for now, and then it's really about prevention, providing prevention information. And 1107 is section 7, and 1108 is section 7. Well, we've got 2 sections. Section 7 is split in half.
Right. Section
Okay.
7 was amending a subchapter.
Got it. Okay. Thank you, Jen, for the clarification. This has been a huge issue for folks, and the number of emails that we've each received is beyond response. I mean, it's just very difficult to respond to each one individually, but we have responded as much as possible. And Kiki's received requests for testimony, and we will put testimony in on 1107 when we get there, or on the whole bill when we get there. Okay. All right,
All right, section 8 was a conforming revision provision directing my office to revise the statutes to replace venereal disease with sexually transmitted infection. If this is something of interest to the committee, I would suggest that we have the time to actually go through and make the changes, so we probably should do that.
you
It's-
do have the time or you don't have the time?
We do, yeah. I mean, this kind of
Okay.
go through and make the changes, sort of a, if it's a major change at the 11th hour, but it's not, so.
So
I think,
we'll leave that one in, we'll leave section 8 in.
yes, but what I'm saying is we may want to approach it in a different way that isn't just directing my office to do it over the summer, but actually doing it in the bill if this is something you're taking up.
Okay,
Section 9 would amend the statute on colorectal cancer screening. Health insurance is required to cover an existing law, colorectal cancer screening. Currently, the requirement in statute is to provide an insured 50 years of age or older with an option of 2 ways of going about that testing. This would instead change that to be at a minimum in accordance with the U.S. Preventive Services Task Force guidelines, which I believe is either age 40 or 45 at this point.
okay.
Section
Well, I just
10.
make sure it's okay with that one. Okay,
Section 10 is
Wait.
Is there a placeholder there? Is that the 3 dots?
3 dots, Jen, can you explain what that means?
3 dots just means there's more to the statute, but we're not reproducing it here, but it's not being repealed. It's just acknowledging that there's more to the statute that is not being shown in this section,
Okay.
because we're not making changes.
Okay,
Section 10 was already addressed in legislation enacted last year. So this was removing the sunset on a provision dealing with pharmacy benefit managers. So you don't need section 10.
Yeah.
Section 11 amends the Green Mountain Care Board nomination and appointment process. And I know we have looked at this one. Some of it is just cleanup language. Now that the board has been in place for more than 10 years, we don't need the provisions relating to the initial terms of members of the board, but there is some new language around the reappointment of a member to an additional term, because that gets spelled out in more detail in this nomination and appointment process.
Right, I know this one, some of the recommendations come out of the nominating committee, and we'll have the nominating committee and to talk with us about some of the issues that they've confronted in the past and how this may or may not help with their recommendations as well.
Great. Do you want to go through the details or just recognize that we've been
No, I
through it?
don't.
And okay,
Unless the committee is.
We're just going through to figure out what we're gonna take testimony on, right?
Yes,
Yeah.
yes.
all right.
Keeping it-
Section 12 deals with health insurance rate review and the information that has to be filed in connection with a rate filing. So in addition to other provisions that have to be included, the summaries that the insurers provide would need to include under the bill the amount of total premium revenue expended on care coordination and management. That is that for that section.
Yeah, I think there might be something we can glean from testimony on this, so let's leave it in for now.
Section 13 amends the requirements, the annual reporting requirements that health insurers must make with the Commissioner of Financial Regulation to include the risk-based capital report. So this is basically their solvency and reserves.
Okay,
Section 14 makes some changes to the hospital budget review statutes. These are not necessarily consistent with the changes you've been looking at in S211. So I don't know how you want to approach, but in this case, the proposal was still uses the September and October dates, which is based on the current hospital fiscal year, which S211 proposes to change. And then it would have the board's budget that it establishes for each hospital, meeting the acceptable range of comparison to the national, regional, or in-state peer group norms set forth in the indicators, ratios, and statistics pre-established by the board, and must be affordable, promote quality care, promote access to health care, protect solvency, and be not unjust, unfair, inequitable, misleading, or contrary to the laws of the state. So all of that language, starting with affordable, I believe, is mirrored on the health insurance rate review statute about what the rates must be.
Okay, well, why don't we compare this with language that we got back from the board, also looking at 211, so we'll leave it in. This will be a bigger discussion with folks.
Similarly, this would make changes in the Green Mountain Care Board statute that sets forth the purpose. This is section 15 of the bill, and these are not necessarily the same as the changes proposed in S211, although I do think it's similar. And so as far as the board, what the board does, it would just specify that they review and approve health insurance rates, hospital and accountable care organization budgets, and ACO certification, and do data analytics. And it would take out some of the other language about enhancing patient and healthcare professional experience of care, recruiting and retaining high quality healthcare professionals, and achieving administrative simplification in healthcare financing and delivery. I think these are some of the issues you're discussing in the context of S211.
Yeah, again, we can certainly compare what's in one with the other, and I know that there will be suggestions coming to us to change what's currently in S211. So for now, we'll leave it, and then there'll be.
I would like this section out. This is a no. This is a no.
So some of the things that are being struck here may be redundant with other parts of the Green Mountain Care Board duties. So that's what I think. You don't see it there, but we'll talk about it.
If this stays in, or anything from 211 comes over, or almost anything from 211 comes over into this bill, I will be against it.
I hear you, Senator.
Okay.
There's a lot of work going on outside and with the folks we sent out of the room to
I think
bring us
that's
back.
unfortunate that a lot of people's times are being wasted, but
Okay, so I'm going to suggest, unless Senator Hardy would not like to take it out. Is there anyone else who wants to take this out? You want to take it out? Okay.
It's 15.
Section 15, yeah.
Section 15.
Yeah, and we'll still be looking at S211, trying to figure out some improvements there. Okay.
Section 16 is, you have the same language, I believe, in S211 requiring, allowing commercial health insurers the opportunity to voluntarily participate in Vermont's multi-payer alternative payment model or models established pursuant to the state's agreement with the federal government. But if no insurers elect to participate, then the Department of Financial Regulation would require insurers to participate as a condition of doing business in this state.
So we've heard testimony, the good, supportive, and testimony not supportive of this one. This is a big policy decision. It's in both bills, so I think we should just look at it at some point.
I still like this one taken out.
And then finally, we have the effective dates. As introduced, the act would have taken effect on July 1st, 2023, except for the prior authorization provisions, which had a delayed effective date. But we are dealing with those, sounds like, in a different way.
Okay. All right, so some progress there. So just to go through briefly, in 151, we're taking out sections 2, 6, 1108 and section 7, taking out section 10, and then ambiguity around section 15 as it compares with S211. So, and I know the 211 is like a little lightning rod in here, but there's a lot of work that can happen to improve some of the systems that we have in place. Better than that. But by strengthening the board and the data evaluation and collection, evaluation and utilization.
May I please pose a process question?
Sure.
So we have these two bills, 211 and 151, and they do cross over in some areas. How are we keeping both of them whole? I mean, are we gonna have two bills or are we gonna combine
We'll
them?
probably
or-
combine them in some way. There are sections of 211 that are gonna disappear. And there'll be changes made so that it will look completely different, I would think. And so, yeah, it's
So we'll
a
end up with
process.
one bill?
Yeah,
Okay.
it'll be one bill.
Just a question for Jen. Jen, what was that statute that, already exists, that, 1108?
It's
Sorry.
18
Okay.
VSA 4226. I can email it to you. I'll email you a link.
Thank you.
Okay, so procedurally, there's a little complexity here. We'll try to, go through and understand exactly what we're looking at and to ensure that we have a bill that we feel comfortable with as a committee, understand some of the concerns that exist, but the goal is improvement. And we've heard from people, there's a need for some improvement to the systematic processes that go on. And I've had conversations, I think each one of us has had conversations with folks representing different interests in the bill. Most important thing for us, I think, is improving patient and access, ensuring predictability, ensuring transparency, ensuring quality, and then cost issues. Yeah,
That's what I was gonna say.
good. I mean, I think we agree. I believe those things, and we don't want to do something that throws out a very good institutional set of organizations, and there are many of them involved here. Okay, so Jen, thank you for that. I think that helps us a great deal. May also help Nolan. Let's see. And we're gonna move on to 263. Is that the next one? Yeah. And that's, we have Senator Harrison coming in to introduce that bill in about 15 minutes. Before we do that, and we'll take a little break. And Jen, unless there's something else that we should be considering, the next time we look at 151, it'll be without those sections. And perhaps what we might do is, we'll deal with 211 going forward, but understanding that we're not ready to put 211 as it currently exists up. So we want to look at maybe some language changes going forward. Then there's there's a concern that's been raised, and I want to speak for Joint Fiscal Office with this concern, and that is that there's a lot of work going on and a lot of demands on Joint Fiscal, and particular, the studies and the reports and the evaluations that are happening. And so I just want us to be very clear. If we start going overboard and asking Joint Fiscal to do too much, remind me that we shouldn't be doing that. Because the demands are very great, and we want to make sure that they're not too much. So that's just a little
It does feel like
red flag out there.
does feel like we have a lot of balls in the air in this committee, and I'm wondering if we might want to go through the list and take some things off. It's feeling like
We'll
there are
keep working
too
on it,
many
Senator. We'll
things.
keep working on it. we always have a lot of balls in the air in this country, yeah.
Well, I think it's just stressful for all of us and for the staff, and it
Right,
would be
so we'll-
nice
we'll,
to pare it down a little.
We'll come back with a discussion on that at some point, and look at the bills that we have. I mean, the most important thing we can do, I think, is to get S-109 out the door. But we do want to give some attention to the bills that have been introduced and some of the senators that have introduced them, and that's the goal. There might be some that we don't do. That's the reality. But we still have, we just had an Alzheimer's bill introduced the other day. Do we just not look at that, or do we invite legislators in to present the? Yeah. So, and there are two bills of ours that are over in the House, one of which is S-18 and one is S-25, and I understand House Human Services has acted on S-18, it is in Ways and Means, and it should be coming back to us, and then that's the vape bill, and then flavors bill, and then S-25, the chemicals bill, coming back to us. Let's see, okay. So I'm gonna suggest that we go off live, and then we'll come back